Chapter 26 in your McCurnin's textbook is the emergency and critical care nursing. Our focus today is going to be more on CPCR and assessment for animals that need CPR, and also crash cart, and then triage. So we're going to focus in on those things specifically for this introductory course. For small animal triage, it starts in the telephone. Somebody's going to call up and they're going to say, my dog was just hit by a car. I need to bring him in right away. And then they're going to hang up. And they may never show up. And so you really need to get, before they hang up, their name and their phone number so you can get back in touch with them to see what has happened. If the animal is in respiratory distress for any reason, we need to see that animal right away. We cannot live for longer than 3 minutes without oxygen. If it's life-threatening bleeding, then one of the first things you're going to need to tell your client is put pressure on the wound. If you have a clean cloth, do that, use that. If not, just put pressure on the wound. If there is active bleeding coming out, especially if it is pulsing, we want to stop it as quickly as possible. That's the kind of first aid advice that you would be expected to give over the phone. If it's respiratory distress, bring it in right away. If it's life-threatening bleeding, put pressure on it and then bring it in right away. We still need that name and phone number. If the animal is critically ill, they've been vomiting for 3 days. Yes, it's been 3 days, but we want to see them right away. If they've collapsed, we want to see them right away. And as soon as they come in, we want to get their signalment, which, if you remember what signalment is, it's their breed, their sex, and their age. If we can get some past medical history, they come in for a seizure, for instance. How long have they been seizuring this time? Have they had a seizure in the past? And what treatment are they on? And then, if we know when this started, it can give us an idea of what's going on. So those are the things that we want to get, maybe over the phone if we can, or as soon as they walk in the door. So triage means we have to figure out who needs the treatment first. So I have 3 examples here. I have tiger, shadow, and spot. What we're going to discuss in class is which one of these goes first. So is the abscess first? Is the respiratory distress first? Or is the vomiting for 3 days first? I'm not going to answer that right here in the lecture because I do want to discuss it in class, but I do want you to give that some thought. If we have a large group of animals coming into the hospital, we want to separate them into 3 different groups, and really prioritize who do we need to see first. In order to do that, we need that brief history. We can do a quick physical exam and then have a very targeted discussion with the owners about what we're seeing them for. We're going to do our quick exam. It's going to just take us a minute or 2. Breathing, bleeding or dehydration, and pain. What are we seeing right away? After that, we're going to do a systematic evaluation of essential organ systems. So obviously heart and lungs would be first, their brain, and then see how if they're dehydrating, how their kidneys are functioning. Those are the most important things right away. After we have them fully registered, we've got all the information that we need, we're going to do a secondary examination once they're fairly stabilized. So we want to make sure that they're on oxygen if need be, they're on fluids, they have a catheter at least placed, and then we can do a secondary exam. Our triage categories are immediate, delayed, minimal, and expectant, or 1, 2, 3, or 4. That's our priority. Generally, we have colors associated with that. So red means got to get on it right now. Stop everything else, go. Yellow means we have a little bit of time, but we're going to need to make sure that we get this taken care of pretty quickly. Green means that we can wait a little bit longer, make sure everybody else is taken care of first, and then we'll take care of this. So a condition that would be typical of an immediate or priority 1 or red category would be chest wounds, shock, open fractures, and 2nd or 3rd degree burns. For delayed, it would be a stable abdominal wound, eye, or and CNS injuries. For green or minimal, it would be minor burns, minor fractures, and minor bleeding. And if the animal is unresponsive, has a traumatic spinal cord injury, or we expect that they're not going to make it, that actually is triage category 4, priority 4, unless everything else is taken care of in the hospital. So our initial diagnostics, as soon as an animal comes in, if we can get a little bit of blood, we don't need a lot of blood, just a few drops to get a packed cell volume to see how much red blood, how many red blood cells they have per serum, in comparison with the fluid that's in their body, their total protein in that fluid, blood glucose. From the arteries, we can get a blood gas analysis. That's a little specialized technique. Blood pressure is pretty easy to get. We do have machines now that we can use pretty quickly to wrap a cuff around the arm and have it measure for us. Pulse oximetry is what is shown here. It's measuring the amount of color going through the bloodstream. So the redder the color, the more oxygenated we assume the blood is. Doing an EKG or ECG to look at the electrical stimulation of the heart. And we can really kind of get an understanding of how big the heart is, how it is pumping, how the electrical motion is going through the heart. And then what we call a fast ultrasound scan. It's literally what it states, but basically it's a quick overview of what's going on in the abdomen, typically the abdomen, looking for hemorrhages or really enlarged bladder or liver or kidneys. Basic first aid. So as we get more detailed physical exam, we look at the spine, we do a complete neurologic examination, looking at the head, the eyes, the pupils, all of the cranial nerves, looking at the oral cavity and the ears. Checking to make sure that if we see wounds, that we're clipping them, we're cleaning them, we're flushing them out with sterile saline. We apply bandages as needed. Going to palpate all the limbs, put on splints if we need to, and get their pain under control or sedate them if they're anxious. And then start our fluid therapy. So we need to have all of these things available to us. We'd like to have an emergency care station. We want it easily accessible, should be clean and well stocked. The equipment should be organized and labeled. We should be near an oxygen source, so we can supply oxygen if needed. Have a suction apparatus if we have an area that needs to have blood removed so we can see better. Having this stuff all with a crash cart. The crash cart, I'm going to show you in a minute, has all of the things that we need in it. And then having functional clippers nearby so we can shave the hair. So here's our crash cart. We want to restock it after every emergency, and we want to inventory it weekly. Things happen in the hospital. You may not be able to find something in the regular drawer, so you go to the crash cart and grab something from there if you need it kind of quickly. We want to make sure that we're always putting things back into the crash cart. We have everything we need there. So what's in a crash cart? So here's a list of things that are actually in your crash cart or should be in your crash cart. Emergency medications, needles, syringes, a laryngoscope so that we can see in the back of the mouth, endotracheal tubes if we need to intubate get into the trachea so we can give the animal some oxygen, and ambubag, which is when we physically move a bag to move air into the lungs, instrument packs, red rubber catheters, and a large bore IV catheter. So these are all things that we will need, and then things to put the catheter, so bandaging material to put the catheters in. These are all things we need. I would add that you'll really want to have either a calculator or a drug chart or medication chart so that you have calculations readily available for different sizes of animal. So what do we need to do if we see a problem with a respiratory system? We're looking at the respiratory effort and pattern, also their mucous membrane color. So remember, what does a mucous membrane color look like if they're not getting enough oxygen through their bloodstream? It'll look blue. So that's called cyanosis. We can measure this with pulse oximetry. We can also measure how much testing if they're sedated and have a tracheal tube in through capnography. That's a specific machine that will measure carbon dioxide moving out of the lungs. We can also take an arterial blood gas. Again, that's a specialized technique. We need to get directly into an artery and draw that sample, immediately push the air out of it, and get it into an ice bath, cap it and get it into an ice bath. If we have any respiratory issues, we want them under oxygen support as much as possible. If we have cardiopulmonary arrest, that means that they are not breathing and or their heart is not beating. So what do we need to do? We need to beat for their heart, and we need to help them to breathe. We need to focus more on, and this is where things have shifted during cardiopulmonary arrest, we need to focus more on getting blood into the cerebrum, into the blood, or into the brain. If we do not have oxygen in the brain, then the body will shut down. So it becomes cardiopulmonary cerebral resuscitation. So we're really trying, our whole goal is to get oxygen directly to the brain. There is one other type of arrest that's not cardiopulmonary. It's not due to the heart or the lungs. It's when it's called vagally mediated arrest. It's with vomiting animals. If they've been vomiting for a period of time, we will see the vagus nerve, which is a cranial nerve. It starts in the brain and goes through the entire body, and it is responsible, it's called cranial nerve 10. It's responsible for a lot of the autonomic responses in the body. And if it gets irritated enough, what it does is it slows the heart rate down, slows the breathing down to a point where it nearly stops or does stop. So we do need to talk about basic life support, so chest compressions and ventilation. And then we'll talk about advanced life support, which is using medications, a defibrillator, and maybe even open chest procedures. With basic life support, we need to pump the heart, do cardiac pump method. On cats and small dogs, we're just using our hand on the sides of their chest, either side of their chest, and pressing in on their rib cage and over their heart so that we're causing the heart to beat. With cats and small dogs, we want that to be 120 to 130 per minute. For medium to large dogs, we're going to need to use our whole hand against the animal's chest at about 100 per minute. Now, if the animal has a flat chest like a bulldog, we're going to lay them on their back and do the chest compressions almost like we do with a human. But if it's a cat or a small dog, they're going to be lying on their side. To monitor if we're actually getting enough blood pumping through their heart to get to their extremities, we want to measure their pulses. So we can use that with a Doppler blood pressure probe. And if we're wanting to measure if we get carbon dioxide out of the body, we're ventilating properly, we want to measure with that end tidal carbon dioxide monitor. So measuring to make sure that we have carbon dioxide coming out. In larger animals, sometimes we have to use interposed abdominal compressions to make sure the blood gets all the way through the body. So we pump on one person will pump on the heart, and then one person will pump on the abdomen. So it's interposed, meaning the heart goes down first and then the abdomen, kind of like a seesaw. If we're not having any luck doing the chest compressions, occasionally we will open the chest up through surgery, and a surgeon will reach a gloved hand in and pump the heart manually. It's not routinely done. By the time we get to this point, the animal is likely not to survive the procedure. We often have to intubate as well, so placing an endotracheal tube just like we would with surgery. If we can't place an endotracheal tube because the animal cannot be sedated, we may have to do an emergency tracheostomy. It's a fairly painless procedure. It's just a quick skin cut through into where you can feel the trachea, and then pushing a tube directly into that just to open up the airway. We can do a ventilatory support at that point. If we can get a tube in there, we can attach an ambu bag, do an anesthetic machine or ventilator at that point. Acupuncture can actually be helpful in stimulating respiration. So we will actually introduce a needle, a hypodermic needle is fine, into a point below the nose, between the nose and the mouth. You can actually feel it on yourself just at the gum line where the teeth meet the gum. Right in the center, where the two halves of the body, the left and the right half, come together, there's a little spot where if we stimulate it, the animal will actually gasp. So I've used that quite a bit in C-section puppies and kittens to get them to breathe, and it's very helpful. So advanced life support, we have to look at what do we need to do if we can't get the heart going and we actually have an arrest rhythm on the EKG. There are 3 different arrest rhythms that we look for. One is asystole, or a flat line, where there is no reading at all. It's just a flat line. The other one is a pulseless electrical activity, where it looks like the animal has a normal EKG or a fairly normal EKG, but there's no pulses. So there's electrical activity going through the heart, but it's not enough to make the muscles move. The last one is called ventricular fibrillation. It's when the ventricles, which are it's the big part of the heart that pushes most of the blood through the lungs and through the rest of the body, is not pumping effectively. It's not getting blood because it's just kind of fluttering. Okay, so it's not pumping blood out, it's just sort of fluttering, and blood is staying in the heart. It's generally, or almost always, preceded by ventricular tachycardia, which means fast heart rate. So it starts in the ventricle. It's being promoted by the ventricle beating too quickly, or the ventricles beating too quickly, and then they're beating so quickly that they fall out of rhythm with each other and just sort of flutter. This will lead ventricular tachycardia, leads to ventricular fibrillation, which will closely be followed by asystole, or a flat line. So when we see ventricular tachycardia, we need to slow the heart rate down. If it proceeds to ventricular fibrillation, we need to do a defibrillation. And that's just a great big shock through the heart that stops the heart and allows the normal pacemaker to start itself again if it's able to do so. If we're going to use medication, we have a couple of ways we can get it into the animal. If we have a vein that is big enough, we'll give it intravenously. If we can't get into a vein, we can put it into the blood, or into the bone, through an intraosseous catheter. Typically that's done with pediatric animals. Or we could put it into the endotracheal tube. There are only 5 drugs that can go through the endotracheal tube and have an effect in this type of support. That would be atropine, and I will tell you in a minute because I've got it written down, but atropine, vasopressin, epinephrine, and lidocaine. And the N is norepinephrine. Atropine, vasopressin, epinephrine, and lidocaine. We can also give drugs intracardiac directly into the heart. Again, that is not done very often because it is invasive to the heart. We do want to present the owner with realistic expectations. When we start life support, CPR, just regular CPR, we are likely to see death occur. If we have to get to advanced life support, it is probably between a 1% and 3% chance that we are not going to be able to resuscitate this pet. And if we do resuscitate, we cannot guarantee the pet will be normal. So we need to understand if the owner, it's also expensive, so we need to keep them informed of this and understand if they do not want to resuscitate. Let's talk about some common toxicities and emergencies we'll see in small animal medicine. The first is respiratory distress. And if we see that, we want to minimize stress on the animal, because the more stressed and anxious they are, the harder it will be for them to relax and take a deep breath. We want to supply them with oxygen, and then we may need to sedate them. With trauma, we want to do our triage examination, make sure that they're breathing okay, that there's no active bleeding. Once we have those 2 things under control, we're going to start to assess the rest of the the body. We may wait to do pain control until we've done our secondary exam to make sure that we've seen where the painful things are occurring first. We want to reassess them continuously because depending on the trauma, there could be underlying trauma out inside the body that we cannot see. So we want to continuously reassess them. An acute abdomen is when we have sudden onset abdominal pain, and we do have to get a complete history to understand what may be happening with that acute abdomen. A gastric dilatation volvulus, or GDV, we will see again acute abdominal pain. It'll be acute signs. We need to stabilize them initially, and it has to happen very, very quickly. And once they're stabilized, they do need to go into surgery to have an abdominal exploratory. This is when the stomach will dilate or bloat and then twist or revolve around itself. And so we'll need to explore the abdomen, twist it back, and then tack that stomach to the body wall. That's called a gastropexy, so that it can't twist again. It can bloat again, but it can't twist again, or it's less likely to. A urethral obstruction is very common in male cats that are straining to urinate or visiting the litter box very frequently and sitting in there, maybe crying in there. Clients don't always catch it, so what we'll see is an animal that has been straining to urinate for 3 days, and then all of a sudden they're stuporous, not acting correctly, may have collapsed because of hypovolemic shock or hyperkalemia, too much potassium in the blood. We do need to sedate them pretty quickly. We need to stabilize them, but also sedate them and then deobstruct their urethra. Toxin exposures are not uncommon. We need to ask questions. We need to decontaminate. A lot of times decontamination means that we induce emesis or make them vomit it back up, but that doesn't happen all the time. We will talk about toxins in a few lectures and talk about when do you not want to make them vomit. And then we could also need to decontaminate through gastric lavage as well, which is doing a stomach pump. EKGs are really important to understand and to know how to do, and then to know how to read. And we'll talk about some good sources for that in learning at EKGs. To set it up, we need to apply these electrodes to different portions, the correct portion of the body, so we can understand what we're reading. If we put it in the wrong place, it's like reading sentences backwards. It won't make a lot of sense. So we want to put the black on the left forelimb and the red on the left hind limb. So smoke, black, over fire, red. And right is white. So right forelimb will be white. The green electrode is not always there. You won't always see it. It's good when we have it. It is the grounding electrode, and it always goes on the right hind limb, which is the only leg that's left if you've done smoke over fire, and white is right. The basic cardiac conduction and ECG waveforms that we're looking for are a P wave, a QRS wave, and then a T wave. And this should look very similar to this when we're looking at lead 2 that's typical of a dog. A horse looks a little bit different, a cow looks a little bit different, a cat looks kind of upside down, but you get used to these different normal EKGs, so it's important to know what normal is. We have to remember that in the heart, there is a specialized cardiac conduction system that starts with the SA node. It creates its own pacemaker. So this is the heart cell that has the fastest rhythm in the heart. So that's the pacemaker. It's the one that sets the pace. It conducts electricity to the cells around it and creates a wave of contractions through the atrium that pumps blood into the ventricles. And as blood is pumping in toward the ventricles, we have this electrical conduction to what's called the AV node, which is the atrioventricular node between the atria and the ventricles of the heart. Then it goes through this bundle of His, which is in the center of the of the septum or the wall between the right and left halves of the heart. And then it comes up the walls of each side of the heart and the Purkinje fibers. And that pushes the blood out of the heart to the lungs from the right ventricle and to the rest of the body from the left ventricle. So these are this is the way that the heart is conducted through, or the electrical conduction goes through the heart. It goes along with this PQRS T wave. So the P wave is what is happening here in the SA node going to the AV node. So from SA node to AV node, this is what the P wave is. So this tells us what happens in the upper part of the heart, or the atria of the heart, the left and right atria of the heart. Then there's a kind of a lag time as the electricity travels through the septum to the walls of the ventricles. So that's our QRS. And then we have a repolarization in the T wave when the electrolytes move back into the cell. So as this goes through, this is creating a PQRST wave, and by measuring how long it takes to get from here to here, from in the P wave, and from here to here, from QRS wave, can tell us how big the atria or how big the ventricles are, and how long it takes to go from one P wave to another P wave. Tells us the rate at which it's going. And if there's any changes in the rate or the size of that complex, that can tell us some changes within the heart. So we're looking for heart rate. So it should be a pretty even rate, unless it's a dog with sinus arrhythmia. Sinus arrhythmia is a normal sinus arrhythmia. It's a normal arrhythmia, normal abnormal arrhythmia, that dogs get because of the shape of their chest, so that when they breathe in, their heart slows down, and when they breathe out, their heart speeds up. So it goes breathe in, beat, beat, breathe out, beat, 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 breathe in, beat, beat, breathe out, beat, beat, beat. And that's just normal for certain dogs, not all dogs, but it would not be normal in a cat or a horse, okay? So that's a normal sinus rhythm that we would see. But otherwise, we should see our normal rhythm should be exactly equal bump, 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 or bump, 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 bump. But it should be the same from beat to beat to beat. Okay? And we can measure it on graph paper by each one of these is a millisecond. So we could measure this specifically to, if we didn't know what the heart rate was, we could figure it out by knowing by reading this EKG. The other thing we would look is rhythm. Like I said, a normal sinus rhythm, an abnormal sinus rhythm. So we got a heart rate, we got a heart rhythm. The complex and the intervals. What's going on with each complex? Is there a P for each QRS? Are they the right size? And then where are they on the mean electrical axis? The mean electrical axis is this flat line here, off of which the P, the QRS, and the T wave are measured. If it's going the wrong way, that's indicating that we have an issue with the heart. Okay, that means the ventricle started this contraction, and that's called a ventricular premature contraction. There's no P wave in front of it. See, there's a P wave, there's a P wave, there's no P wave. That means that we have a secondary AV block. There's a block in between the atria and the ventricles. And then all of a sudden the ventricle goes, wait, I haven't beat in a while. I need to beat now. So that's a ventricular premature contraction, and that can be indicating a problem. So normal sinus rhythm. This is a sinus arrhythmia. You can see that this looks a little closer than this. Okay, we'd have to see a little bit longer tracing to make sure that's normal. Sinus bradycardia is when we have a very slow heartbeat, but there's a P wave each time you see a QRS. And a sinus tachycardia is when we see a P wave for each QRS, but it's very close together. It's very fast. Okay, so those are some basic arrhythmias to understand. Like I said, there's ventricular tachycardia, which leads to ventricular fibrillation. That's when we don't have a P before the QRS, just a lot of QRSs in a row. They look fairly normal. And when it goes to fibrillation, it just looks like it's gone crazy on the EKG. And that's when we need to defibrillate. Okay, we're going to talk about horses. So most commonly with horse emergencies, we're going to see colic. That's part of the GI system typically, but colic can mean any pain in the abdomen. So it could be reproductive as well. The respiratory system, we do occasionally see respiratory distress, and then a lot of musculoskeletal issues. So fractures and lacerations are pretty important, pretty common. Two potential waves of action: we could send in the doctor to the field or to the barn itself, or we could say to the client, we need to refer you to a hospital because we can't do this in the field. Talking about colic, there are two categories. So it's anything that causes abdominal pain. The first category is something that's mild. It's going to resolve with minimal to no treatment, some medical treatment. And then the second category is it's not going to resolve with medical treatment. We need to send them in for surgery. It is potentially life-threatening, and so we do need to be prepared for it. When we do a colic examination, we need to look for pain. We need to look at the horse's attitude, look at their temperature, pulse, and respiration, their mucous membrane color, their capillary refill time. All of that is fairly normal stuff, but then we need to listen to the gastrointestinal motility. We need to listen on 4 quadrants on each side of the body. So on the left side of the body, we're going to listen to the upper left abdomen, the cranial dorsal abdomen, the caudal dorsal abdomen, the cranial ventral abdomen, and the caudal ventral abdomen. So you need to know your locations, right? But each one of those should have gut sounds. We should be able to hear gastrointestinal motility through that. So we call that borborygmus. We should hear some stomach rumbling. So we're going to listen with a stethoscope to the abdomen. If we think there might be a bloating or distension, we're going to listen to the abdomen and also ping the abdomen or percuss it with our finger, flick our finger on the side of the skin of the abdomen so that we can listen to the sound of if it's gas in there. So think of if you were to tap on a basketball, you can hear a certain sound because that's gas inside. There's air inside that basketball, or say a yoga ball or exercise ball that's bigger. What is the sound difference there? So you can hear if something is a tight a piece of intestine that's fairly small that has a lot of gas in it versus some intestine that's fairly large that has gas in it. We want to submit some blood work. Some signs of pain, it's important to know horse facial expressions and also to watch their behavior. Mild pain, they may be pawing or stretching out, maybe a curled or tight lip and standing quietly. Moderate pain would be if they're doing the mild pain stuff and or kicking or rolling, and our sedation it helps, but only for short periods of time. Severe pain is when they're throwing themselves on the ground, they're rolling, they're kicking themselves, they're banging their head on the side of the ground. You can see evidence here that this horse has been doing that, and sedation has no effect. So we look for this history of severe pain. So they may be in moderate pain or mild pain now, but they may have had severe pain earlier. We're going to look for that in horses because we're not watching them 24/7. So we're going to do a complete colic workup. It starts with nasogastric intubation, which means we're sticking a tube into their nose, down their esophagus, into their stomach, and we may flush water in first, or we may just see if we have any fluid coming out, and that's going to tell us something. We can do an abdominal palpation by sticking a gloved hand into their rectum and feeling for bloated intestines. We can also do abdominocentesis, which means we're sticking a needle into a surgically prepared spot underneath their belly at the lowest part of their belly to see if any fluid is accumulated there. We can do an abdominal ultrasound. We can do abdominal radiograph or x-rays just on small horses or foals because you need a really powerful x-ray machine to do anything bigger. And then last thing that we could do is an abdominal exploration or surgery. With respiratory tract emergencies, most commonly we see an upper airway injury where we have obstruction of airflow to the lungs in the trachea or in the nasal cavity. Remember, they are obligate nasal breathers, and so they must breathe through their nose. So there's any damage along that line, we're going to have a respiratory emergency. They can get lower airway disease, lung disease, where they have difficulty inflating their lungs. Probably the most common cause of this is like chronic obstructive pulmonary disease or COPD. We call it RODS or heaves in the horse. Basically, it's an allergic reaction to dust that causes inflammation and mucus production in the lungs, and they have difficulty inflating and deflating their lungs, breathing basically. Musculoskeletal injuries, second most common in second to colic. So we'll see fractures, lacerations, infections of the joint, the soft tissue in the foot, and sometimes luxations of joints. And these can be severe and life-threatening. Wounds we're most often going to see on their distal limb because if they kick out and come into contact with loose metal, wire, wood, or other horses, we do have to be careful that these wounds don't become life-threatening. There are a lot of bacteria in their environment. Tetanus is a big problem and can cause infection in the wounds pretty quickly. So we want to get a general examination and pay attention, especially to possible blood loss. We might have to do a joint tap if we have a wound around a joint or an injury around a joint. We need to do a surgical prep of that joint area and stick a needle in it, see what we have as far as joint fluid. May send that away to a lab or examine it in the hospital. When we need to do wound management, we're going to clean it with antiseptic soap or betadine solution, rinse it with saline, try to decrease further contamination through bandaging. If we have necrotic or dead tissue, we want to debride that or remove it and remove any foreign material, dust, dirt, debris, splinters. X-rays are the best way to get assessment of bony structure involvement. We can generally do that with extremities, or we can look and see if we have what's called a bone sequestrum in muscle tissue or in the joint. So if we have a fracture around a joint or in the muscle, and look for any bone that's in the wrong spot. Can use ultrasound to evaluate tendons and ligaments that we can't see very well with x-rays, or to identify foreign bodies that don't have mineral content. So in order to see it on an x-ray, it needs to look kind of like a bone or be more dense than bone, like metal. If it doesn't have any mineral content, it's not going to show up on x-ray. So we can use ultrasound, for instance, to look for splinters, like wood splinters, if they've kicked something like a stall. If we do need to do wound closure, most of the time that we do wound closure, if it's not a major wound, they'll be sedated and standing. Remember, horses can sleep standing up because of a locking mechanism they have in their stifle joint, so it allows them to stand pretty easily while they're sleeping. Really depends on the temperament of the horse and the severity of the injury and what the preferences are of the owner and the veterinarian. With food animals, we really need to anticipate each step. It can be very difficult to restrain, so we need a cattle chute or some type of way to safely restrain larger animals. Some considerations that we have to take into consideration is that there are regulations that involve what we can inject into or give to medications that we give to animals prior to slaughter. And so if it's an animal that is severely wounded and we need or has an emergency that they may not make it, we may choose to slaughter versus give them medication. So the GI system, they do get bloat, they do get twisting of intestines and parts of the GI system. So we want to do their heart rate, respiratory rate, temperature, TPR, like you would normally do, evaluate the lung and heart sounds, and then also auscultate their abdomen, just like we do with a horse, and do some percussion. We want to ping. We want to hear that rumen. We don't want to hear too much gas in the rumen. We want to make sure that there's no other gas sounds around the rumen either. And then rectal palpation is often done as well. We can also do ultrasound, abdominal ultrasound, abdominocentesis, radiography if they're smaller, like a goat or sheep, and then some blood work. We often will do emergency intervention. So, doing a surgical surgery on a cow in the field or at the farm is more common than doing a horse surgery at the farm. And we can do pretty invasive procedures. So, if we have twisting of the abomasum or the cecum, or we have a bloat of the rumen, or something's going on where we need to do surgery. This is something that you'll see. Sometimes they have stalls at the farm that are clean and ready to go for surgery. If they have a lot of cows, the veterinarian can go straight there, or they will bring the cow to the hospital and they'll do the surgery here. This is a typical clip of abdominal surgery. The animal will be standing. We'll do an epidural, so we'll stick a needle into the spinal cord and get some pain relief there. And then this ridge of this line here that you see here is the part of the vertebra of the spine. It's the transverse process that sticks out on the spine. So there are vertebrae all along here, and there are spinal nerves that come out along the vertebrae. And because we can feel the vertebrae, we know where the spinal nerves are coming out, and we can block those spinal nerves right there. And this will block this whole area within the abdomen, and they'll be able to not feel anything and stand there and chew their cud or eat or whatever they're doing while we do surgery on them. The other thing we'll do is a block of the skin here with lidocaine or something similar, so that they really don't feel anything from the skin all the way into their abdomen. Some specific GI conditions that are emergencies would be diarrhea if it's severe, because it can cause dehydration and hypovolemic shock where they don't have enough fluid in their body to maintain blood pressure. We can give them oral fluids and electrolytes, or we could through a tube. So we place a little gag in their mouth and stick a tube through it so they can't chew on the tube. And this is called a Kingman tube here. Or we can give them IV fluids. Parasitism. So having parasites can be an emergency, a GI emergency. Haemonchus contortus is a blood parasite. It's called the barber pole worm. It's something that affects all ruminants, but most often goat and sheep, and cause profound anemia, and often they need a blood transfusion. Rumen emergencies are a problem as well. So if they have a bloat, we call that ruminal tympany. It becomes like a big drum. It's excessive gas accumulation, so we may need to do a rumenostomy. We actually put a hole into the rumen and allow air to escape. This is a trocar. It's actually fairly big. This would fit in my hand, but just it would stick out of my hand a little bit. But it has a point here, and I would create an incision in the skin and then just punch it right through into the rumen, and then I would screw it in there to keep it in place, and it would keep the rumen attached to the body wall. And then I would remove this center pin, and that would allow air to escape. And this is the Kingman tube here. Choke is esophageal obstruction, so it's when we have an obstruction of the esophagus. This happens in horses as well, and usually hedge apples are the culprit. They say, "Oh, that looks really, really good," and I will just go ahead and chew on that, and it gets stuck. So if they are unable to eat or swallow, and there's a lot of stuff coming out of their mouth and just kind of flowing out of their mouth, then we want to try to massage that down. Maybe put some esophageal tube with some mineral oil, lube that up, and massage that down into the rumen. They'll eventually digest it. The rumen bacteria is so important to their overall health, and the pH of the rumen is really important. So if anything is off in the rumen, it can make them very, very sick. So we want to test the rumen pH, do a test called the methylene blue reduction test, and that helps us to determine the amount of good bacteria that is in their rumen, and look at that under the microscope. If we have a rumen that doesn't have the proper amount of microbes in the rumen for the animal to be healthy, we can actually use a donor cow. This is a cow that has been made into a rumen donor. She is kept very healthy, and she has a hole that was surgically made into her side, and her rumen was sutured to the side of her, so there's a direct opening into her rumen, so we can just reach in there and grab that stuff, or we can get rumen fluid out of a cow by placing a Kingman tube out and pumping fluid out, and straining it through some cheesecloth, and then just taking that fluid and putting it through a Kingman tube into another cow, and that's called a transfaunation. It's like eating probiotics through yogurt, but it works better for cows if we do it directly from the rumen. So some other things that they can get is they get respiratory distress, which is a life-threatening condition, and they may need a tracheostomy. Choanal atresia, we see this in alpaca crias when they don't have an opening into their choana, which is um, uh, their respiratory system. It goes from their oral pharynx into their nasal passage. And if you remember, llamas and alpacas are obligate nasal breathers. And so if they don't have a passageway from their pharynx into their nose, then crias can't breathe. So if a cria, baby alpaca, is having trouble breathing, they need to have a tracheostomy so that they can breathe. Orthopedic emergency, if they have a fracture, lameness that makes them go down and not be able to stand up, we call that a downer animal, and that's a problem with large animals. We have to get them up off of their little legs so that they can get blood flow to their legs so they can maintain the ability to stand. If not, they will die. So this is called a hip lifter. To assist them up, it fastens around a cow hip. They have very strong pelvis, and it sticks out quite a bit, so we can put those loops right around the iliac crest of the pelvis and use a pulley to lift them up. We can also use slings, whole body slings, or float them in water for a short period of time. So they can get distal fractures, they can get proximal fractures. Proximal fractures are usually mean the death of the animal. Luxations, more common to get shoulder and hip luxations in these big animals. Um, they can be down animals because of sepsis or shock or major infections. Hypocalcemia and hypokalemia, those are electrolyte imbalances. Orthopedic problems. We can see dog and wild animal attacks pretty frequently on sheep and goats that can cause blood loss, contaminated wounds, and of course rabies. More commonly, we're going to see rectal and vaginal issues, dystocial and obstetrical emergencies in which we will do a rectal and vaginal exam fairly quickly when we're doing a physical on them. Epidural anesthesia is pretty common with emergencies. If we see a dystocia, we can do a vaginal or C-section delivery. Small ruminant dystocias, because they're so small, we have to be very careful to do a we have to be very careful to do a um, use a small hand so we don't rupture anything. With uterine re-show here, we see it pretty commonly in cattle and camelids where the uterus will actually, after a really rough birth, their uterus will actually turn and twist, and we can correct it by this method called plank and a flank. There's a plank of wood that they actually have, and somebody's standing on it to put pressure on that plank, and they have the animal on its side, and that plank holds the internal structures in place while the people turn the cow around the plank so that, that you're turning the cow around the twist so that it untwists the interior organ. It's different, and that's why I show it, but it's still used to this day. Uterine prolapse is really common in especially high producing dairy cows where they have a calf and they push so hard because they have so much calcium and their uterus is contracting so well, they're actually pushing the uterus out as they push the calf out. If that happens, we have to the uterus will get trapped and so it will swell. So we have to reduce the swelling. We have to clean it up. We have to push it back inside, which can take a lot of time and effort. It's taken me 8 hours of constant pushing at one point to do one in a cow. Then you have to suture it back in place by suturing the vulva closed temporarily, until the scar tissue takes hold after a week or so. They can get toxic metritis, which is where their uterus becomes infected. And they can also get toxic mastitis from a really bad bacterial mastitis from the mammary glands. In small ruminants, mostly males that have been castrated, because their urethra isn't as big. It's not uncommon if they have get more grain than they should and decreased access to water that they will have a mineral buildup in their system and that will create uroliths or calculi in their urethra, which will get stuck. So these little stones, it's like this little string of pearls here, will get stuck, and especially because they have this sigmoid flexure in their urethra that causes a curve, and it makes it very difficult to catheterize and fix that. It's an example of a dystocia box and equipment needed if we have a dystocia or a difficult birth. These are all the things: sterile sleeves, sterile lubricant, sterile obstetric chains to help pull the calf out, a calf jack, which is, I'll show you in a minute, feedotome, which is if we have a calf die inside the animal, we actually have to take the calf apart by cutting it in pieces before we take it out of the cow. A cray hook will hook to the nose of the calf to help pull it out. Eye hooks will attach to the skull not in the eyes but around the eyes, or inside the eyes. We're not hurting the eyes, we're just attaching it to that particular point of the skull. A finger knife if we do need to make a cut on the calf. Buckets, pumps, and uterine lavage tube, and fresh towels, right? So this is very similar to a crash cart. Any questions, please bring those to class and we'll cover them. A lot of emergencies, a lot of things I can't show you because of this introductory level of this course, but you will definitely see them in clinics.